Wonderful. Are we ready to go? Okay. Good afternoon. I assume that everybody is dialing from the East Coast of the United States, so I will say good afternoon. I'm in Richmond, Virginia. I just drove down for the day today, and my name is Amry Junaideen. I am a marketplace leader for Deloitte, which is a large professional services firm. But the reason I'm doing this is because I also happen to be the chair of the board of directors for the American Heart Association here in the Greater Washington region. And heart health is something that I have had personally been impacted by, because a lot of my members, the extended family, have been impacted by heart disease, and I have personally been on a statin for the last 20-something years. I'll provide some of my personal experiences here as well, but I'm really happy to host this dialogue. Our 20th Men's Health Symposium, Empowering Your Cardiovascular Health. Today we get a chance to have a really candid dialogue about this topic that men in particular are not terribly comfortable with, which is kind of interesting, and we'll kind of delve into that. A huge thank you to our sponsor, Suburban Hospital, and Johns Hopkins Medicine for bringing this conversation to life. We would also like to thank the Frederick Bowles Community Fund, who has supported the Men's Health Symposium for over 20 years. Today, we will hear from a medical expert and someone whose life changed in an instant. Please welcome Dr. Anthony Keller, a cardiologist from Johns Hopkins Community Physicians Heart Care, who is here to answer all of your questions. And also welcome to Jonah Czerwinski, I'm hoping I'm saying your name right, who has quite the story to share with us. Jonah, you really look very well. So obviously the care that you received seems like it's kind of worked, but I'm really excited to hear your story. So with that, let's kind of get into the content here, right? So Dr. Keller, I'm going to start with you. Men, for the most part, I can speak for myself, might avoid seeing the doctor, right? And particularly, we might go and see our GP every year, but, going and seeing a cardiovascular specialist or a cardiologist is something that we are kind of reluctant to do. What's the psychology behind this? Why is this the case?
Well, it's a great question, Amry, and I'm sure there's been master's theses written on this very topic. But I think it's manifold. I think one of the big problems is that men are not socialized to go see the doctor as women are from an early age, because women have woman exams, OB concerns, mammograms that they're doing all through their early years, whereas often men never make it to the physician's office for a routine physical until their middle age, until something catastrophic happens that forces that. So I think there's a huge component of that. And I think every physician who's been in practice can tell you multiple stories of the man who ignores a problem until finally some generally female relative or close friend basically horse collars them into the office to make them get care. And it's unfortunate, because I think proactive healthcare screening saves lives.
Yeah, like I said, I can relate to that as well. I mean, they say that men are more likely to take their car for their service when the thing, when the dashboard tells you that it's required to take it to the service station. So what can be done to change that dynamic, right? What can we do to convince more men to actually go and get their preventative health screens?
Well, I think rather than installing a horse collar on all men, as I previously alluded to, I think it's all about awareness. I think the truth of heart disease is that the vast majority of heart disease and strokes can be prevented through appropriate management of those conditions. And so it's really about that recognition and hopefully lowering the barriers to care, to getting folks in and giving our frontline healthcare workers the resources they need to facilitate those conversations and those appointments, those medications, all the information, resources, education that folks could avail themselves to.
Yeah, it's interesting, Dr. Keller, because I was asked to take a statin 20 years ago when I was much younger. And my doctor in Connecticut, and I told him, no, I'm going to handle this with exercise and diet. And he said, listen, no, you've got a specific kind of propensity or proclivity because you're South Asian and all of that. He said, I'm not trying to prevent a heart attack today, but I'm trying to prevent something 20 years from now. And I'm glad he persisted because I actually rejected him for 12 months. So it's also, I think, about having medical professionals who basically persist with their patients, right, and show them the way.
That was very prescient of your doctor because the data has only accumulated in the last 20 years as to the effectiveness of the cholesterol lowering drugs, and the guidelines have gone through multiple iterations since then. But the consensus was less clear then, but has become only more clear that lower is better.
Fantastic. I'm going to go to Jonah next, but before that, I'm going to share some statistics to set the stage. According to the American Heart Association, every 34 seconds in the United States, someone has a heart attack. Heart disease is the leading cause of death for men in the United States, accounting for about 1 in every 4 men. I mean, think that those numbers are staggering. It's also, of course, the leading cause of death of all people. What is a heart attack and what can contribute to them? So, Jonah, you've had an incredible story to share with us. Over to you.
Well, thanks, Amry. And those are some jarring statistics. Nobody wants to be a statistic. And I know there was one myself. Last year, just to give everyone a sense of a real world experience, what I went through was certainly preventable, avoidable, but nonetheless a surprise. And I was on an annual trip with a group of buddies of mine, and I really looking forward to it. Had a few days marked off, and I noticed though before heading out, I was having some pain in my shoulder that was bothering me. I went in to see my doctor about it and said, I play a racket sport. Could this be associated with that? He assessed me and said, you know what, you probably do have a rotator cuff injury. When you get back, let's have that checked out. We'll start some physical therapy on that. Well, this was only a 3 or 4 day trip. And within a day, the pain started getting worse. We were in Perry County, Alabama, so far from where I live here in Washington, D.C. And I reached back to him and I said, look, this is not getting any better, but I'm hoping maybe you can prescribe some kind of anti-inflammatory, something that can help me deal with this discomfort until I get back, which he did. And as the first day became the second day, things became even more, I don't think I could say discomfort anymore. Now it was just painful, but it was nonetheless tolerable, probably because of all the distractions, being on a trip with good friends and good food and lots of things to do. Well, on the final night, it had gotten to the point where my entire upper body was just, I could not describe it in any other way than just in flames. And I have had, of course, even at this point, not thought what I was enduring was a heart attack. I thought I was enduring an adverse, reaction to a combination of these anti-inflammatory medication that was just prescribed while I was down in while I was traveling. And so still really recognizing the emergency that was underway. It wasn't until about 2 o'clock in the morning I reached out to one of my buddies there and I said, you got to take me to a hospital. And of course, our host, his family's home in rural Alabama, said, well, that's good. The nearest one is about 30 miles from here. It's not a hospital either. It is an outpatient clinic. We hopped in the truck and got there as fast as we could on fumes in the gas tank, nearly running out of gas on a country unlit road. We were more concerned that we would just get stranded, let alone that I would even make it to the site of care. Fortunately, we got there. in time for them to administer was it a TPA, clot buster medication, which immediately stabilized me in one sense. But they took my blood pressure just before that, and it was 200 over something. I don't remember what the something was at that point. I was too agitated and in pain. So they combined the TPA with morphine, fortunately, that after which I don't remember until I woke up from the Birmingham hospital, which was another 40 minutes away from there, that I was brought to in an ambulance, I guess. Woke up and was stented. Had been given surgery with a stent. Some complications soon after I woke up, resulting in me being brought back into the cath lab, another stent installed, and woke up from that with a balloon pump in my chest because it couldn't pump sufficiently on its own. The heart needed this assistance. Net, what we ended up having happen here was something called a STEMI, or ST elevated myocardial infarction. I get a lot of new terminology as a result of this experience. These things used to be academic to me at most, now quite personal. And a STEMI is a pretty lethal experience. It's oftentimes one that you don't actually have the opportunity to be treated for. My lower anterior descending was blocked. They call it, I learned very quickly, a widowmaker for a reason. But fortunately, the crack team there at Birmingham was able to take care of me. My wife showed up within the first 24 hours. And the friends of mine who took care of me while we were down in Alabama were there at my side too, which made all the difference as well. 4 days later, I was discharged, wearing a wearable cardiac defibrillator. For everybody on this webinar in the audience, picture a skin-tight vest with wires and pads attached to a very heavy battery that you wear over your shoulder. And you wear it 24/7 for 6 months, waiting to see whether or not you might just need to be charged back to life. It's a pretty disorienting state to be in for that long. Combination of a sense of security as well as foreboding all the time. Anyway, so Amry, that was. That's what transpired there. I can give you guys some more color about what transpired after being released from the hospital after day 4, being given the clearance to fly back home with my wife, rejoin the kids back here in Washington. But it's a pretty harrowing experience, and one that did not guarantee an outcome where I'd be joining you here today. So I feel fortunate, but like I said at the beginning, I also feel like this was not a guaranteed event. And I hope one of the things we can talk about here are the things that, actions we can take as men looking after our own health, and those of us, caring for other men who are seemingly just fine, but we're talking about what is now a young man's risk factor, and not just one that we think of as old men, enduring in retirement by any means.
Jonah, that's an incredible story that obviously turned out very positive, very happy. You talked about the widowmaker, right? One of my very close friends at work, one of my partners, her brother in Nashville, Tennessee, last week, basically had 46 years old, came back home, otherwise healthy person, or in quotes, came back home after a baseball game. Literally collapsed on the living room floor. The wife tried to administer CPR. By the time the ambulance came, unfortunately, he was gone. Right, 46 years old, massive attack. There are so many kind of lessons we can take from your story, including prevention. But I want to focus a little bit on the 3 or 4 day trip itself, right? Now, you actually finally went to the hospital only on the final day, right? But you had the chest pains even kind of before the trip. What is it that
Correct.
you would have done differently, or what would you encourage other people to do differently if you were experiencing those kinds of pains and you had this trick coming up, right? Because those are the kinds of the realities that people deal with on a daily basis, right?
Well, yes, and I think you're getting at something very fundamental, which is this is not just about prevention. This is about listening to your body in the moment, and we all have a tendency, at least most I think of us do, to kind of downplay things and say, well, I was only too willing to accept the diagnosis of it's a rotator cuff injury, for example, rather than being a little more questioning, inquisitive about it. But here's the thing that I would say to that. During those days when I was on the trip, if you were to ask me, what are the symptoms of a heart attack? I would probably have been able to tell you, let's see, left arm pain, shortness of breath, the typical things. I'm not an expert like Dr. Keller here and yourself, but I am definitely aware of the conventional wisdom, I guess, as far as that goes. And at no point would I say my left arm was hurting. At no point would I say shortness of breath, although I was experiencing what we would now call that. And I think we need to understand that when we use terms like shortness of breath, we need to unpack that a bit for people to understand. Here's what that feels like. It's not like you just ran a sprint. It's different. It's like when you just take a few steps and there's a pressure in your chest and you kind of have to catch your breath. It's not the same thing as running a sprint, being out of breath. The terminology makes us think of things that are different from what we're actually experiencing. And we need to help people understand the warning signs are a little more unique and at the same time, knowable, but they're just not what you might associate with conventional terminology around shortness of breath. And left arm pain, we say that too, but what we really mean is upper body pain. It can come in different places. It doesn't have to be left arm. I didn't have any of that, but I definitely had the associated warning signs. So I think it's important for us to realize that there are warning signs we think of, and then there are what they actually feel like in real life, and being willing to say, it could be inconvenient to disengage from what I'm doing right now, especially if you're on a trip in the middle of something. But the risk of missing out on something or disrupting something is obviously worth the trade-off. Had I gone in even on that first day, we would have found a worsening blockage, but we wouldn't have had a heart attack like what I ended up experiencing. Not have even resulted in certainly anything as severe as 2 stents. And by the way, here we are now several months out, 6 months after I went in for surgery, and I have no longer a wearable cardiac defibrillator. I have an implanted pacemaker for the rest of my life right here, because my heart had undergone so much punishment for those consecutive days that the damage had been done. I wouldn't have this here because my heart would have had a stronger ejection fraction, would have not suffered the same amount of scarring and damage. Had I been able to recognize what I was enduring was actually symptoms of something far worse than a rotator cuff or a reaction to an anti-inflammatory.
Oh, it's quite incredible. Dr. Keller, unfortunately, you've probably seen this or heard this story play out many, many times, some that ultimately turn positive and some not. Your comments just generally, and there's also a question in the chat from the audience, and I think Jonah sort of answered it, right, in terms of what could have been done differently.
Yeah, I think, Jonah, there's so much to share in that story, and I think I often joke that if anyone comes in with any kind of a symptom between their upper lip and their belly button, they get to see a cardiologist, because unfortunately referred pain is so diffuse. We are not wired well to know what angina feels like, because our caveman ancestors knew what a branch was versus a saber-toothed tiger. But if Grandpa Ugg from 10,000 years ago was having a heart attack or heartburn, there was nothing he could do. So we're just not wired well. And so you always need to maintain an index of suspicion. And I think that's a little hard because, the classic teaching is that Jonah, you should have been the typical patient with typical precordial chest pain pressure, what I like to call the red fox syndrome, here I come, Elizabeth. But unfortunately, we don't all read the textbooks, and I've seen many forms of folks coming in with very isolated elbow pain, shoulder pain, neck pain, nausea, abdominal pain. So I think recognizing those symptoms and listening to your body to say, if I've been playing racquetball for years, why is my shoulder hurting now? And it's really easy to diagnose a heart attack in retrospect. It's much harder to do it when the patient's in front of you. So I have a certain sympathy for your family physician or whoever missed that. But I also think that just the early screening of just knowing what your risk factors are, and I think that goes back to the first question of why do men not seek care, is that we think that we are absolutely indestructible, and remembering that it takes a blood clot the size of a ball bearing to really make you suffer as you have, Jonah.
Yeah, and that is a good point. And I think, Dr. Keller, you reminded me of another point that maybe is worth also mentioning here, which is around the screening piece of this. I think we're beyond the point where we should consider it judicious. We should be overly cautious about screening. I don't really care how expensive screening is and the like. I don't think we should. There is prevention we can do, but there's also the things that only our more sophisticated screening can pick up on. That's not obvious to even the most attentive primary care doc or informed future patient. When I went in, we talked about my rotator cuff, and one of the questions was, "Hey, I exercise, I'm in good shape. Could I still get a heart attack?" I'm not in different shape right now physically, in terms of my body fat, my my general physical state than I was before. I was active, played squash regularly, saw my primary care doctor probably more often than most guys my age do, and I had elevated blood pressure and elevated cholesterol. But look, we talked about it in terms of lifestyle changes. And Amry, my doctor, 20 years after yours, was still thinking we should wait until we put you on a statin, I would say this: they're cheap, they don't weigh a lot, it's not a lot to ask. Accept the imposition, taking a damn statin every day for the rest of your life, and that life will be longer, clinically proven to be true. I would just say we should be much more aggressive in terms of both the screening and err on the side of caution when it comes to prescribing such things as statins. They are a no-brainer, and I know that there are several factors going into that decision, but I think it's clear in hindsight that I was one of those situations where there was only downside to prolonging, initiating that kind of medication, and I'm on it now, and will be for the rest of my life. But this was conversation we had was less than a year before the heart attack happened. Less than a year later, this is what occurred. So I believe that there's plenty more we can do from changing mindsets around that posture around being too passive with such things as that.
Yeah, if you look at the conventional risk calculator, the American College of Cardiology, American Heart Association has the atherosclerotic cardiovascular disease risk calculator, which calculates a 10-year risk. And the big factor in there, and always the number one risk factor, age. Mm-hmm. And you violated that, Jonah. You cheated. But the other two big risk factors that come out in that, or there's several, but tobacco use, blood pressure, and cholesterol. And the blood pressure, I think, is a critical piece because it is so silent that I deal with this every day in clinic of the person who doesn't check their blood pressure, but everything, they come in, they're 160/90, but I've got white coat hypertension. Well, we need to prove it.
Exactly.
I don't trust that blood pressure cuff in my clinic any farther I can throw it. I need you to go buy one, and they're not prohibitively expensive. And then looking at those cholesterol numbers, cholesterol is a and Jonah, thank you for kind of leaning forward on this one. There was a great article just yesterday in the New York Times about cholesterol that they're looking at changing the guidelines a little bit. And there's a cardiologist at Cleveland Clinic named Steve Nissen, who's been a big name in the research community for decades now. And he apparently is pushing to get Crestor, rosuvastatin, generic over the counter, which I love. I applaud that because the benefit of the cholesterol medications of the statin drugs is so high. 95% of the folks tolerate it just fine. If you look at the other medications that you can buy off the shelf, aspirin, Tylenol, Sudafed, Aleve, these are all far more dangerous drugs than statins are. They just predate the FDA. So the FDA grandfathered all those in. And meanwhile, statins, which are proven life prolonging drugs, are still require my prescription. So, but looking at those numbers to facilitate that discussion, and even routinely in clinic, I think because the statins are all generic now, I've gotten very liberal about prescribing them, even in folks who might be considered conventionally low risk, based on some trials that have shown that, again, in otherwise low risk folks, that there's some significant anti-inflammatory plaque stabilizing effects that can prevent heart attacks, even in folks who we don't think of as being high risk. So, it's hard to guess, but Joan, if you were on a cholesterol medication, I think this may have been lessened. It's hard to say it would have been prevented, but plaque stabilization, lower cholesterol. So less plaque just means less area to rupture and to cause that heart attack, but also keeps it from entering the vessel wall or exiting into the vessel, which causes the heart attack.
I'm glad you mentioned, and sorry, Amry, I was going to say one thing here. I'm glad you mentioned the white coat syndrome and the heart blood pressure cuff. I had exactly this happen. And imagine if you don't go in to see your doctor very often, as most men don't, whenever you do go in, that is the only time you get your blood pressure taken. And what's the question that I would always get? Is your blood pressure always this high? Yes. Yeah, I only get it measured when I come here. And every time I come here, it's high. And yet we didn't talk about, that being a red flag. Where it seems pretty obvious that you need to start measuring that sort of thing at home. Much like we have the scale in our house, having a reliable blood pressure cuff, could not agree more strongly. And I obviously have one now. That is a basic measure that we can take that helps add more data to the overall gestalt. Like, how are you actually doing? Because the doctor can only know so much when you show up. And that's an important metric that is generally unreliable. But only do it when you go to see the doctor.
Yeah. So, Dr. Keller, I think you've touched on this quite a bit in the last few minutes, but there's a question from the audience about the specifics around elevated cholesterol and blood pressure. When does elevated become a cause for action? How does family history tie into that? Would you mind just talking about kind of the conventions that are now out there, right, in terms of when the numbers become concerning?
Yeah, so that's such a hard question because it is such a continuum. If your LDL, bad cholesterol, is above 190, you are familial hypercholesterol, you need to be on medication. If it's below 70, you have preternaturally low cholesterol. And everyone lives in between, not everyone, but 95% of us live in those two standard deviations between an LDL of 70 and 190. And so I think this is based a lot on practitioner experience, but I can tell you most cardiologists are very aggressive with our statin treatment. Even just today in clinic this morning, I started a gentleman on a low dose of a statin because his cholesterol was up and he had a concerning family history and he was in his 70s, and he's kind of my target audience. I think when we're looking at risk stratification, that ASCVD risk calculator I alluded to really focuses on binary variables, variables that are very easy to say yes or no. The blood pressure and the cholesterol are more continuous, but we have robust data from years of studies. But when we start to look at family history, that gets a little mushier. I'm not sure if that's a word, but I'm going to use it. Ethnic origin. We know that some folks from certain areas are at higher risk, and again, there's very few of us that are really truly entirely Norwegian or entirely Cameroonian. So again, that gets mushier. Another great example is chronic inflammatory diseases. Rheumatoid arthritis has long been recognized as a cardiac risk equivalent, but there's just not enough people out there, and there's a spectrum of disease for rheumatoid arthritis. So I think that you really, at some level, there's got to be a gestalt where you put all the pieces together and you have that shared decision-making discussion between patient and clinician. And then sometimes you need to take another step and do other testing that might help further refine that risk. One test that I order a lot of is the calcium score. Calcium scoring is a very quick, inexpensive CT scan. It's literally one breath hold. You go into the tube, it goes, and basically anyone who's watched TV enough knows that calcium on either a CT or a chest X-ray comes out very bright, very dense, because the radio waves do not go through calcium. And calcium is the matrix. When there's inflammation in a vessel bed, it lays down calcium as the kind of the repair structure. And so a normal coronary artery should not have any calcium in it, but over time, when you're having these subclinical events, it lays out calcium. So the calcium score is a bit of a logarithmic scale for anywhere from 0, which is an A+, and I've seen calcium scores as high as 3,000 or 4,000. So it's exponential. But that's, I think, a wonderful way of further defining risk, that oftentimes I will see someone in their late 40s who says, I'm concerned, my dad had an event in his 50s, my cholesterol numbers don't look terrible, my blood pressure okay, and that calcium score can really be a nice tiebreaker.
You know, you'd be very happy to know, Dr. Keller, that about a month and a half ago, I actually had my a CT angio done, which is interesting. I have my score, which I shared with 2 of my cardiologist friends, and we talked about it. I want to talk about back to the rotator cuff, and I want to tell you a personal story that you haven't heard, which is a few years ago, I had chest pains, went to a doctor. I was actually overseas at the time, and went to a cardiologist, and he was very concerned, and he actually did a radial angiogram on me. And so this is one where I was actually watching the action on a little television screen while he was in my arteries. And he said, except for some terminal arteries, which had some stuff in it, he said my arteries were absolutely clear, right? And then it was attributed, the pain was attributed to, I lift some weights, muscle ache, muscle pain, right? And I went on to live the next several years, without any pain. The reason I tell you that story is now, when I do get a chest pain, right, I'm inclined to think it is a muscle pain versus some cardiac event, right? So for a person like myself, how do you kind of get out of that kind of mental dichotomy, right? Of, oh yeah, I went through this pain and it was nothing. Why should I now think that it is something that I should be concerned about?
I think, again, this is a master's thesis discussion on Bayesian logic that unfortunately, I think you have to kind of keep re-challenging. And I see a lot of worried well, and I'm always happy to, because I mean, that's my job, is to, what's the old Hippocratic oath, to comfort always. But I really think, I used to say that I remember having newborns was the hardest time for me, because with a newborn baby, they don't respond immediately. So the baby cries, so you change their diaper, you swaddle them, you try and feed them, you make them warm, you cuddle them. And if they're still crying at the end of that, you just kind of start over again. and you do all the same things again, because the newborns don't have that good response that they say, okay, I'm happy now, thanks, gotcha. And so I think of chest pain or somatic symptoms very much like that, is that you kind of have to run through your differentials. And I think, you know, not to be an alarmist, but you really have to start with the life-threatening things. And so seeing that physician, and sometimes you're going to have to go to the emergency department and let them tell them that you're okay, and then you'll get a follow-up with me in a few weeks. But I think you just have to keep that healthy dose of suspicion for any changing symptoms or any persistent symptoms, and especially concerning exertional symptoms.
Sure. I want to ask a quick question about LDL, and then I'll get to a question that's been asked by the audience here. So, Dr. Keller, I was told by my prevention doctor, wellness doctor recently, that if your LDL is above 70, that calcification begins. Is that myth or is that truth?
We have used, or the guidelines have used LDL as a cutoff, as that is our target. For Jonah, your LDL goal is 70. Back in the olden days, the guidelines, there were all these cutoffs. It was unnecessarily confusing. But honestly, I would like to see everyone at 70, because there's really never been shown to be a lower level at which your LDL causes any problems, any dysfunction. So I think, unfortunately, that's probably a bit of an oversimplification, because it's a continuous variable. It's not a binary variable. But I think, just generally speaking, as a man over the age of 40, I know my Grecian formula is wearing off. I think maintaining that low cholesterol, ideally through lifestyle and healthy eating through exercise, is critical. But obviously, sometimes we have to resort to pharmacotherapy.
Sure. That's a great segue, because the question that I have from the audience is really about lifestyle. So I'm going to start with you, Jonah, and then have Dr. Keller weigh in as well. Anything you would do differently or would have done differently from a lifestyle perspective, or advice that you would give to people in terms of one of those biggest lifestyle changes or best practices that you would advocate to the audience here?
Yes. Actually, one of the most important things that I think I appreciate now is that when we talk about lifestyle and diet, if you're not in one of the other visible risk factors, like you're not obese, it doesn't mean you're omitted from these lifestyle and diet requirements. And I had absolutely in my head that, well, I'm in good shape. I'm active, and therefore I can eat pretty much what I want, because it's not going to, because I can keep that from becoming, an issue around my waistline. And obviously that was insufficient. So for those of us out there who are on the outside in good shape, we don't get a pass on making sure what we put into our body is makes sense for what goes on inside our body. I absolutely did take that seriously. I stayed active, that part of the lifestyle, but I always tended to overlook the consequences of indulging in the food I love to eat. And no doubt that was something I could have controlled but didn't. From a lifestyle standpoint, there's one other thing that maybe we don't talk about very often, and that's sleep. There's, and I'm sure Dr. Keller can tell us more about this, but the data around the importance of sleep on our health status and heart health in particular, as well, is pretty robust. And when you're in your 40s, you've got all sorts of stuff going on in life. You've got work, you've got kids, you've got all sorts of demands, and you're trying to do everything you possibly can. Sleep is the thing that we usually, compromise on as a result. And you'd be amazed how easily you can get by with less than you need for a while. So regular, not just enough sleep also. I think that's another big part of it, is there's something to be said about the consistency. going and making sure that you impose some order over this part of your life too, is going to sleep at a, doesn't have to be at a particular time, but at around the same time, and doing that as a habit, as well as working out as a habit, as well as trying to eat better. That's another big factor. So don't don't think that the eating healthy part is only for those of us who want to lose weight. Obviously, it plays a much bigger part in all of this, and that's a change that I've been having to make for sure, as well as the sleep part of it, because I believe that actually makes a big difference as well.
Yeah, I mean, I know that the American Heart Association, we've been starting to talk about this concept of food as medicine or food as health. I think there's absolutely something to be said about that. And by the way, it's not just about heart disease, prevention of diabetes and all kinds of other ailments.
Absolutely.
So it's healthy eating. So Dr. Keller, anything to add to that from a lifestyle perspective?
Well, I always love lifestyle because it's stuff that anyone let's show of hands, who's graduated from middle school? We all know what the right answers are to this, right? Stay active, plant-based diet, avoid the fast food, the salty, the stuff that unfortunately tastes good to us. Try and drink plenty of water. So I think Dr. Oz, that show, I've never really watched it, but my understanding is that, he tries to sell these simple solutions, the green bean extract that, prolongs, supports healthy aging, or what else? The weight loss gummies. I mean, it's just insanity. There's no easy answer. This is just being regimented about exercising, eating right, and a great point about that Jonah makes about sleep. One of the biggest risk factors we're seeing, and it just, every study shows this more and more, is sleep apnea. And sleep apnea is basically where generally associated with obesity, but not always. And that's where the airway shuts off when you fall fast asleep. And so you never get that good restorative night's sleep. And folks who have that are at increased risk for coronary disease, for atrial fibrillation, for diabetes, for a whole host of metabolic abnormalities. And so I'll bang the table on that one, Jonah. Thank you for bringing that up. I also just want to touch real quickly a couple of good questions in the chat. The one lifestyle modification I would say is activity, is exercise. It's really hard to integrate to your lifestyle, and I think that if everyone was able to spend 30 minutes a day getting their heart rate up, we would all be a whole lot healthier. And the other question from the chat was the cardiac parameters between men and women. There's actually no difference. That's probably because we just don't know, and there probably is some differences. The truth is, when we talk about LDL, for instance, we're talking about a group of particles. There's different subparticles, and so there's probably different effects and probably some hormonal differences, but we're still working on that. And those questions will be probably answered in some of our lifetimes, but I don't think in my professional lifetime.
Yeah. So I want to pivot the conversation to what happens when somebody is experiencing a heart attack, for example. I want to talk about CPR specifically and the use of an AED. In our offices around the country, for example, we just installed AEDs on every floor in every office for more than 100,000 of our people. And already we have kind of proven that it can save lives. So Dr. Keller, let me start with you. Any words of wisdom on CPR and AEDs and how easy or difficult those things are to learn?
AEDs, they actually have, they talk you through it. It literally has a voice that says, apply electrodes. It yells at you. And so you apply the electrodes, stand back while it analyzes the rhythm, shock advised. And you literally hit the big red button. There's one button. So no, it's almost like that Geico commercial. It's so easy a caveman could use it. Those AEDs are lifesavers. And the sooner you can get those things on, the sooner you can get them out of that life-threatening rhythm. Absolute life-saving. So I can't speak highly enough about that. And I think the move towards getting AEDs in public places, in gymnasiums, and schools, and community centers is saving lives. And I agree with you, Amry, that I think the data is showing that. The other thing is CPR. We all learned CPR where you press 30 times, then you give 2 rescue breaths. And interestingly, the Japanese experience, they had a hard time because people didn't want to do mouth to mouth, and they really proved that just hands-only CPR, that if you're doing good compressions, you know, 1.5 inches, 100 to 120 beats a minute, or compressions a minute, you're not only going to get, you're going to maintain enough blood flow to keep the person alive, but you're also going to ventilate their lungs well enough that they're getting oxygen delivery as well. And so again, I think this just goes back to what we were talking about before, is that this is just a little bit of information. It does not, you know, learning how to use an AED, learning how to do CPR literally is a 10-minute video, and you will be an expert. And you can save a life, because the data for out of hospital cardiac arrest is abysmal. If I were to collapse, even in my office surrounded by medical professionals, my chances of a meaningful survival are fleetingly low.
Jonah, anything around CPR? For example, did you know how to do CPR before to use an AED? And has your experience changed how you view those sorts of things?
To answer your last question there, yes, my experience has definitely changed my perspective on these things. Because I'll tell you beforehand, the first thing that would come to my mind with AEDs, and I don't think this is all that unique, is that you think liability. Should I use that? What if somebody collapses? Am I going to be the one? Well, if you don't, everyone else is thinking it. We're just observing the inevitable. But there needs to be some education around the fact that there is, that anybody can do it, like Dr. Keller was saying. It's hard to screw this up, and you have a duty to do it. If you're there and present. And I beforehand would never thought about it other than the risks of engaging, which is really laughable if you really think about it. And now, after having that wearable cardiac defibrillator for 6 months, basically walking around with an AED attached to you that could go off, it was at once jarring, but at the same time a bit comforting, knowing that this was kind of ever present. And it makes me appreciate the installed ones that you see around, knowing that more of those are better. Closer they are, that it could happen anytime to virtually anyone. So I'm much more aware of them now as well. And I hope we can destigmatize the idea that being the one to administer it is something we should seek to be, and not be afraid of the consequences of maybe screwing that up, because it's hard to, and and if you don't, no one will.
Yeah, there's something in the chat that Roxana put in there about the Good Samaritan law, right? Because Jonah, you started out by talking about the risks. Can you just, either you or Dr. Keller, kind of explain what the Good Samaritan law is and why the risk and the liability is not what somebody might think it is?
I can give you a layman's perspective, perhaps, but Dr. Keller, he referred to the Hippocratic Oath. One aspect of that being "do no harm." I think we may have over-indexed on that nowadays, and say, "I just don't want to make him worse." And the Good Samaritan imperative around it doesn't matter who it is, they deserve help, is kind of in conflict with that from a practical day-to-day standpoint. Now, there's a certain degree of obligation that we probably don't realize that we've got, but you do realize how dependent you are when you go through this. And it puts me in a position of thinking, I really hope everybody understands their obligation, because that could happen to me. And I have a duty to do the same. But from a layman's standpoint, this is really, it's very abstract for a lot of us to think that I would have a role to play if I am standing next to a stranger who suffers something that results in them collapsing, and instead turn that around to say, forget about the do no harm thing. embrace the principle of you have an obligation to treat the Good Samaritan approach. I think I like that a lot more.
There's a question from the audience, Dr. Keller. Even if I exercise and eat healthy, can I still have a heart attack?
Unfortunately, there's no warranty on life. So yes, the data suggests, and of course there's no way to fact check this, but about 2/3 of heart attacks are preventable. That, if we have, I'm going to make up a number here, 1 million heart attacks a day in the United States, we don't. But 2/3 of those are preventable if we could get them to stop smoking, if we could get them on a good medication regimen, if we treat their sleep apnea, if we ... So unfortunately, I can't with a good conscience say, yes, everything is preventable. You just need to see a cardiologist and let us work our magic. But I think if you're using the law of averages, yes, most heart attacks are preventable through healthy habits and treating what can be treated.
Can I add something to that in terms of the law of averages real quick, Amry? There's another, from a patient standpoint, from an individual standpoint, I also, and I think a lot of people can appreciate this, embrace a law of averages in terms of eating healthy and exercising, thinking that when I'm at home, I eat very healthy with my family. I'm compensating for that when I do not eat healthy. On average, I'm doing well. And I realize I did that all the time, and it doesn't work that way. I'm no nutritionist, but it's clear that I was not balancing. I was compensating for any healthy eating I was doing by thinking that I could just sort of average it out. Just wanted to make sure I made that point too. It was something that I needed to consciously change.
That's awesome. Dr. Keller, there is a question from the audience about the popularity of the semaglutide drugs for weight loss. Wegovy advertises more cardiac benefits than the others, Ozempic, etc. How is Wegovy different in terms of cardiac health?
I wish I had a good answer to that. I'm not familiar with that data. Generally, when we're talking about similar drugs, they don't compare. There's no head-to-head Ozempic versus Wegovy or Ozempic versus Mounjaro. What they do is they compare themselves to whatever the typical, be that just diet and exercise, or maybe even bariatric surgery. I don't know that data very well, but so I am always very suspect when one drug says it does something better, because the trials are never exactly the same. What I can say is I'm a firm believer in the semaglutides. I think that obesity, unfortunately, is epidemic, and it is our birthright. Again, going back to Grandpa Ugg. Grandpa Ugg's my favorite character. I talk a lot about Grandpa Ugg. He lived where he had to fatten up during the summer, and then during the winter he would lose weight, and that was just the reality of life. And now we live in an environment where we have 365 days a year of food abundance. And I think some of us are very inclined to put that away no matter how hard we try. I don't think that, I think obesity is a disease. And so I think that any of those drugs, you're going to see an improvement in their metabolic profile. You're going to see fewer cardiac events. That's been shown. You're going to see improvement in diabetic control. And even just an article came out just a few weeks ago that showed that the kidney outcomes, that your kidneys do better with weight loss as well. So I do not have any commercial ties to the semaglutides, but I think that for a treatment of obesity, they are becoming a cornerstone. They've become a cornerstone.
So we're very quickly winding down. As they say, when you're having fun, time flies. We're almost out of time. We talked about a lot of the factors. I want to just press one more time on stress management, because I've also heard that, all those dots, right? That stress also could play a role in cardiac health and cardiac disease. So Dr. Keller, let me start with you on the whole stress management piece of this.
I'm a big believer in in kind of mindfulness and trying to, my go-to, my mantra is that old, oh gosh, the guy who wrote Infinite Jest, he had a "This is Water," which is a commencement speech he gave at Kenyon College, where he talks about just realizing that this is life, and not to get so tied up in it. And it's a beautiful piece. But I go back and read that periodically because I find it very grounding. I often have patients say, should I go on disability because I had my heart attack and it's because of work stress? And I say, this is life. You're going to have stress if you're at this job or if you're unemployed and living on welfare. And so I think it's kind of up to you to find that spiritual, that reflective. And for a lot of us, it's exercise, that time in the gym is when you put on your music or your podcast and you go to your happy place. And so I unfortunately, I think stress often veers from my strike zone and into other medical specialty strike zones. But certainly I think living on, when you're frustrated with work and home and financial and emotional and health, I think it definitely takes its toll after a while.
Jonah, any comments to add?
Well, one of the hardest prescriptions for me to adhere to immediately following the heart attack was, Jonah, you have to stop working for 1 month, which I took to mean, you mean like less than 8 hours a day, but probably about normal, no work for a month. That took me a week to figure out. So I wasn't really acclimated to that. But what I'd say is that there's a reason why that was so important. It wasn't because I was going to, be unable to do my job. It was because it was going to interfere with my recovery, and it was an emergency measure. It really was. It was like an extreme measure, no work at all, because we can't run the risk of this complicating your immediate recovery. The answer to this is not to avoid the stimuli. Like Dr. Keller said, like, what are you going to do? Not go to work ever? No, the answer is to figure out how to respond to the stimuli. And that is, a different area of medicine and care that we oftentimes also don't understand very well. And that's the mental health, care side of it. That as guys, we tend not to go see our cardiologist. We don't even have one. We usually don't have a psychologist either, or a psychiatrist. Hopefully that'll change over time, because it really is a big contributor to heart health, but not something that I had thought of before as something that was anything other than to be tolerated. But it really is something that we can manage better rather than avoid the stimuli. It's just a fact that we can get better and better at that, and the answer isn't to just run from it, kind of a thing. So hopefully folks understand, that's definitely a different discipline, but as critically important as physical heart health, in my opinion anyway, for longevity and just quality of life.
Fantastic. Jonah, thank you very much for being here and sharing your real life story. I think I tell the AHA all the time that these real life stories really, bring things to light in a very understandable way. So thank you for being here. And Dr. Keller, thank you. Your insights were phenomenal. And also reading about your background, thank you for your service as well to our country. So with that, we're going to close out. Thank you to the Suburban Hospital, Johns Hopkins Medicine, for bringing this conversation to life. And please take the time looking through all of the amazing tools and resources available at the American Heart Association website. So thank you again, and have a great rest of the day.